To kick things off, we are looking at Dr. G.S. Raju's YouTube.
It is a fascinating place to start.
It really is. You know, when we think about anatomy, we usually picture those pristine diagrams.
The ones in the doctor's office, all color-coded and neat.
Exactly, like a subway map.
Yeah.
But today we're doing something a little different. We're going, well, I'm calling it biological spelunking.
I like that. Spelunking. It implies darkness, depth, and maybe a little bit of the unknown.
Right. We're on a journey into this hidden landscape that's inside all of us, but that we almost never get to see. We're diving into the stomach.
And not the cartoon version.
Not at all. The real, squishy, dark, complex terrain of the actual organ. And the best part is we're not using a textbook. We're looking at the messy reality.
Right, and that's what makes this so interesting. The source material's intended audience. This isn't just a general overview. We are looking at a guide made for endoscopy nurses and technicians.
And that perspective, it just changes everything. It's not just, here's the stomach. It's here's how to navigate it without getting completely lost.
That is the core idea. It's all about situational awareness. I mean, if you're the technician standing there, you're just staring at a monitor showing this confusing pink tubular world.
Yeah.
You need to know exactly where that camera is without the doctor having to spell it out every second.
Because it's dark, it's wet, and let's be honest, everything kind of looks the same if you don't know what you're looking for.
It's a biological tunnel. And if you don't know the landmarks, you are absolutely lost. This is basically a survival guide for staying oriented in there.
So it empowers the technician then. It makes them an active navigator, not just a bystander.
Exactly. They can track biopsy locations on their own.
Okay, so we're going to be the guides today. We'll follow the endoscope's path, start at the top, slide down the esophagus, map out the stomach walls.
Perform some camera gymnastics.
Yes, and then figure out how to use a clock to tell location inside a tube.
It's a journey from the cardia to the duodenum.
Sounds like an adventure.
Yeah.
So, segment 1. Crossing the border, we're going down the esophagus, which is a straight shot, I assume.
Yeah. Pretty much. But then you hit the gate.
The GE junction.
The gastroesophageal junction, yeah. Once you pass that muscular ring, you're officially in the stomach. And the very first room you enter is the cardia.
The cardia. So if I'm the camera, what am I seeing right now?
Well, visually, as you pop into the cardia, you're often looking at what the source calls a couple of holes, and you get a view down the lesser curve of the stomach.
Okay.
It's the entryway. But right away, the whole texture of the world changes. You're not in the smooth esophagus anymore.
Right. This is where we run into the rugal folds, which honestly sounds like something from geology.
It's a great term, and they really define the upper and middle thirds of the stomach body. You have to picture the stomach lining as not being flat. It's bunched up like heavy curtains.
Or like an accordion that's been squeezed shut.
Yes, exactly. Or a plowed field. These folds, they run parallel to each other, sort of lengthwise, and the source makes a really important distinction about where you see them. This is your first big navigational clue.
Okay, so if I'm lost in the tunnel, where are these folds?
Well, if you're looking at the greater curve, the big outer sweep of the stomach or the front and back walls, the folds are everywhere. They're thick and deep.
Like a canyon floor.
It does look a bit like that, but, and this is critical, they aren't everywhere.
Oh.
If you look at the lesser curve, that's the inner, tighter side, you don't see many folds at all. It's much smoother.
So that's a massive clue for orientation. Heavy parallel lines means I'm probably on the greater curve or the walls. Smooth means I'm looking at the lesser curve.
You're reading the terrain. But there's a problem with these folds, medically speaking. If you're looking for, say, a tiny ulcer, it's not going to be sitting on top of a fold waving a flag.
Right. It can be tucked deep inside one of the creases, like a crumb between sofa cushions.
Precisely. Which brings us to a key procedure in the source. You have to distend the stomach.
Which is the polite way of saying you pump it full of air.
Essentially, yes. You inflate the organ to stretch out those folds. It's like taking a crumpled map and smoothing it flat on a table.
You have to open up the valleys to see what's inside.
You have to. If you don't distend it enough, you are missing half the picture. A good technician is watching for that.
Okay, so we've inflated the room, we've smoothed out the map. Now we're pushing the scope deeper, moving down to the lower part of the stomach. And the scenery changes again.
It does. It's a really distinct transition. As you get to that distal third, the rugal folds just stop. They fade away.
So we're leaving the canyon and entering the plains.
Good analogy. This smooth area is the antrum. You can actually see it from a distance as you come down. It looks like a smooth tunnel leading to an exit.
And that exit is the pylorus.
The gatekeeper. It's the muscular valve that lets food out. As you push through the smooth antrum, that little opening of the pylorus gets clearer and clearer.
Okay, so we've got the rough folds of the body, then the smooth antrum, then the pylorus exit. But the source really emphasizes another landmark here, the incisura.
The incisura is maybe the most important lighthouse in the stomach. It's a structural landmark on the lesser curve. Think of it like a permanent ridge.
A ridge, like a speed bump.
More like a sharp corner. It marks the transition point between the antrum and the body. But here's the trick. You don't usually see it that well just driving straight ahead.
Why not? Shouldn't a big ridge be obvious?
It's all about the angle of the camera. Because it's on that tight lesser curve, you might just breeze past it. To really see it, the source explains you often have to pull back a little and physically look up.
So you have to crane the camera's neck, so to say.
Exactly. You angulate the tip upward. When you look up and see that distinct arch, you know exactly where you are.
This idea of looking up is a perfect lead into our next part, the gymnastics. Because apparently you can do some serious acrobatics with this thing.
You certainly can. The flexibility is remarkable. The source describes a maneuver where after you've seen the lower parts, you rotate to the right and literally flip the scope.
A U-turn inside the stomach.
A complete retroflexion. You're bending the camera 180 degrees or more, so it's looking back at itself in the very top of the stomach.
And when you pull that J-turn, what are you looking at?
You're looking up at the fundus.
The fundus sounds important. It's just the top part.
It's the dome-shaped upper part right under the diaphragm. And when you look at it this way, you get another texture check. Just like the antrum at the bottom, the fundus at the top is typically pretty smooth.
Okay, so smooth at the bottom, smooth at the top, and rough in the middle. That's a pretty reliable map.
Generally, yes. And while the scope is in that U-turn position, the operator does something specific. They keep the camera angled up, but they push the scope physically deeper.
Wait, okay, my brain is... The camera's looking up, but the tube is moving down.
Yes. Imagine you're sliding down a rope while looking up at the ceiling. As you slide down, you see the walls passing by you in reverse.
I see. So you're scanning the wall by sliding past it while looking backwards.
Correct. And this move gives you an incredible view of the greater curve. Then by straightening out and pulling back, you get this full, sweeping view all the way back up to where we started.
It really is a dynamic dance, isn't it? Between the instrument and the anatomy.
It is.
Which brings us to maybe the most mind-bending part of this, the cartography.
The clock face.
Right. Because here's the problem. You're in a round, squishy tube.
Yeah.
You're twisting, you're flipping. How do you tell someone exactly where a weird spot is? Left is meaningless if you're upside down.
Left and right are subjective and, frankly, dangerous in endoscopy. You need an absolute reference system, a grid, and the source lays out how to create this grid using the antegrade view.
Antegrade meaning looking down the normal way.
Yes. So when you're looking down into the stomach, you have to mentally overlay a clock face. But any clock needs a 12, a North Star.
So what's the stomach's North Star?
The anchor is the lesser curve. Remember, the side with fewer folds.
The smooth strip?
Right. You orient your view so that the lesser curve is at 12 o'clock, top of the clock.
Got it. Lesser curve at high noon.
And once that's locked in, the rest is logical. Directly opposite, at 6 o'clock, is the greater curve.
The one with all the long folds?
Yeah.
Okay, 12 is smooth. Lesser. 6 is rough. Greater.
Exactly. Now, on that clock, 9 o'clock, the left side of your screen becomes the anterior wall, the front wall.
Which means 3 o'clock is.
The posterior wall, the back.
Lesser, greater, anterior, posterior. 12, 6, 9, 3. It sounds simple, but the source does say that biology isn't always so neat.
True. It notes sometimes the stomach has a weird configuration, and the lesser curve doesn't sit perfectly at 12, but you get as close as you can.
And why is this so critical? I mean, if you just take out a polyp, isn't the problem solved?
Not always. Think about the clinical payoff. A doctor removes a polyp. If they just write remove polyp from stomach, that's useless for the future.
Right, it's like saying, I found a rock in the park. Which park? Where in the park?
Exactly. But if they write polyp removed at 55 centimeters from incisors on the anterior wall, they're giving GPS coordinates.
So 5 years from now,
a different doctor is doing a follow-up scope. They read the report. They know exactly where to look. 55 centimeter anterior wall. They set their clock, look at 9 o'clock, and boom, they're checking the scar for recurrence. It creates a reliable map for the future.
It turns a random observation into hard data. That's actually really cool.
It ensures continuity of care.
So We've mapped the stomach, spun around, used the clock. Now we're finally heading for the exit, past the pylorus and into the duodenum.
The first part of the small intestine.
And the source gives a little pro tip here, a hack, really. Because just getting into the intestine isn't enough. You have to stay there.
Ah, yes. The cap trick.
Yeah. Apparently the first bit of the duodenum, the bulb, is a slippery place.
It is. The pylorus wants to close. The duodenum is active. It's super common for the scope to just slip right back out into the stomach before you get a good look.
Like trying to park on ice, so what's the fix?
The source suggests attaching a clear plastic cap or hood to the end of the scope.
A little plastic attachment.
That's all it is. But it creates friction and stability. It gives the scope a little bit of grip against the walls.
So it stops you from sliding backwards.
Exactly. It lets the scope stay in the bulb, which gives the operator time to properly inspect the walls without fighting to stay inside. It's a game changer.
Simple, but effective.
Very. And once you're stable in the bulb, you can push deeper, and the landscape changes again.
How so?
We've left the long rugal folds behind. Now in the duodenum, you see circular folds.
So not lengthwise anymore.
No, these go around the tube, like rings.
Oh, like the ribs of a vacuum cleaner hose.
That's a perfect visual.
Yeah.
Yes. So immediately, just by the texture longitudinal versus circular, if you're in the stomach or the intestine, you're just reading the walls.
It's incredible how distinct these zones are. You'd think it would all just look like one thing, but it has neighborhoods.
Distinct neighborhoods, yeah, with their own architecture.
So let's just recap this tour. We slid down the esophagus, crossed the border into the cardia.
We saw the parallel rugal folds of the body, prominent on the greater curve, but gone from the lesser curve.
We inflated the room to see between the cushions, then moved down to the smooth plains in the antrum.
Found our lighthouse, the incisura ridge, by looking up and back.
Then we did the full backflip, the retroflexion, to see the smooth dome of the fundus at the top.
And we applied the clock face lesser curve at 12, anterior at 9 to create our map.
And finally, we used that little plastic cap to stop from slipping out of the duodenum where the texture changed to those circular rings.
A complete journey.
What really sticks with me isn't just the anatomy. It's that whole effort to impose order on what is basically chaos.
That's the key takeaway for me, too. That clock face idea is so profound. You're in a biological environment that's shifting and moving. There are no street signs.
There is no north. Yeah.
By imposing that grid, that 12 and 6, you turn a subjective feeling, I saw something over there, into objective data. Lesion at the 9 o'clock position. That's what allows medicine to be scientific.
It really is amazing. And I want to leave everyone listening with this thought. We all have this complex geography inside of us, valleys, ridges, smooth plains. And there are people whose entire job is to navigate that dark, shifting world upside down just to make sure we're okay.
It highlights the incredible skill. It's not just medical knowledge, it's spatial intelligence in a 3D world in real time.
Absolute spatial intelligence. It makes you appreciate that inner space a whole lot more.
It certainly does. And that wraps up our look at Dr. G.S. Raju's YouTube.
Thanks for listening, everyone. We'll see you on the next Deep Dive.